Okay. And how important is it to kind of make the public understand that what we know now might be different than what we know in September, and what we knew in March was different than what we know in May, and how much of a living, breathing um, thing this is?
Yeah, I think that is so important because we are learning more every day. And like you said, what we thought a few months ago may not be the case now. Um, we have, as a secure IBD group, in interviews and publications and in the weekly newsletter we send out, we try to reinforce that and update the community constantly, both the physician community and the patient community, as we're getting new information and as that information is changing. So we're trying to spread the word that, you know, what we know now might not be what we know later. And another way that we are trying to help in this setting is by having a website that every week we post our most recent data. So when we have more information, then we want the public to have more information as well. So we've been trying to reinforce to everyone that it is a moving target, and keep checking back to our website because things may change.
And now the pandemic has forced a lot of shelter in place and canceled medical appointments. How have gastro doctors been able to screen and diagnose new patients?
Yeah, so I think initially the pandemic did lead to some delays in screening and diagnosis of new IBD patients. I think initially resources were overwhelmed, elective endoscopies were canceled, there were resource limitations, and I think there was a lot of understandable patient concerns about reporting to care and about visiting a medical facility in the setting of a pandemic. I think now, though, that's starting to shift because most practices and healthcare facilities have had enough time to implement appropriate safety protocols. And I think now it's important that we are sort of going back to providing the care that the patient needs and not delaying endoscopies or not delaying important diagnostic tests for patients who need them. But that said, I think that we can also utilize our resources that can accomplish our goals while maximizing safety. And I think that's things like telehealth, which connects providers to patients in a safe and accessible way. And then also non-invasive testing, such as fecal calprotectin, where we can get a sense of a patient's disease activity without a colonoscopy.
Okay. Is there fear that maybe there are people kind of neglecting that initial appointment, and there's more people out there with IBD that haven't been diagnosed yet?
I think there is, and I think that there is still a subset of the patient population who is, quite frankly, scared to present to care. I mean, I've had anecdotal experience where some of my patients, and as a pediatrician, their parents, who are worried about coming in, and even if their son or daughter is having bloody diarrhea and the symptoms of a flare, is asking, what can we do at home instead of coming into the hospital? And that's required some extensive conversations about our safety protocols and about the risks versus benefits and what can we offer at home versus what can we offer in the hospital. And I'm hoping with continued education, and particularly education about the safety protocols that are in place, that's gonna ease the fear of some patients. But I do worry that people are presenting later to care and at a point where their disease is more severe because of this pandemic.
Okay. And has there been any progress made in researching whether some of the common IBD drugs can be effective in actually treating the virus?
Yeah, so I think that's a great question, and has really exciting potential, because a lot of the morbidity and mortality associated with COVID-19 infection is related to the overwhelming immune response of the body, and a lot of our IBD treatments, the way they largely work is by decreasing the immune response. So in theory, you would wonder whether these medications could actually be used to treat COVID. However, I think as with any new medicine that we are investigating in terms of whether it can treat a disease, real randomized clinical trials are needed before we can say whether or not they're effective. So for instance, the biologic medications, I know that there's a phase 2 clinical trial going on out of Tufts Medical Center looking at the efficacy of infliximab for treating COVID-19. I think that's really exciting, and that's what we need. There is some, anecdotal evidence case reports. I can think of one where, a 14-year-old developed the Kawasaki's-like syndrome in association with COVID and then had a very quick and favorable evolution following infliximab induction. But that I consider purely hypothesis generating. And the same with the secure IBD data. We're seeing in our raw data the percentage of patients on the anti-TNF medications, both monotherapy and combination therapy. The rates of severe COVID are lower than the rates in the overall secure IBD cohort. Again, this is our raw data though, and then we have all of the limitations of our epidemiologic study. So I think, where the money is really is those randomized control trials.
Okay, and my final question is, in terms of gastro and COVID, what's the most important thing to look for in the next couple of months?
Yeah, so it's a question of whether it will be in the next few months or 6 months or a year, but one aspect that I am really interested to look at is to see, if our patients with inflammatory bowel disease or other chronic GI conditions, whether their serologic response is going to be similar or different from the general population, whether they're going to mount antibodies to this virus in the same way as the general population, whether, if and when a vaccine comes out, whether they're going to have the same response to the vaccine as others. So that's the data that I'm really excited about, but I think it's going to take some time for it to come out.